Hello class and welcome back to our lecture over the contents of the vertebral canal. I just wanted to finish this up and talk about the spinal nerves and some of the other attributions of the vertebral canal. So we're going to begin with some radiculopathy, talking about a pinched nerve. We've mentioned this before, but it's worth repeating. And this is where we start to think of a compressed nerve somewhere along the back. Now, it is worth mentioning that L5 is one of the big nerves that can also become compressed because it is very thick and it goes through a very narrow space. And so if you have some type of degeneration of the disc, or if you have some type of osteophytes that might, or herniation of the disc, that can definitely contribute to that compression. And a very common area that gets compressed is the L5 to S1 area. And so when we think about back here, we can see that L5 is kind of contributing that lateral thigh and that leg as well, the anterior leg there, all the way down to that lateral foot. And then the S1, which we can see right there, is that posterior thigh. So it is very useful to get to know your dermatomes. So we will start introducing them and learning your dermatome maps, because it's very useful clinically when somebody comes in with a pain that might be, let's say, in the posterior thigh, and you might think it's a compressed nerve. Sciatic is a good example of this. Well, you can guess that the compressed nerve might be around L5 or S1 or S2, depending on that level. So this will help you understand where to get your images and where to take your images and where to look for that damaged nerve. So the sciatic nerve, which we mentioned, is going to have contributions from the L4 to S3. So we're talking about those parts of the sacral plexus, which we'll get into later on. And then this is often caused by a herniation of the intervertebral disc that's going to either compress one of those two nerves, the L5 or the S1 component of the sciatic nerve. So we'll see this again with the lower limb, but I just wanted to bring that out there for you now so we can get this concept, if you would, of a dermatome. And a dermatome is when we think about the area that's supplied by a single pair of spinal nerves. And these maps are very useful for us. And so we will begin at least with the back and the back of the head to understand these and what they're referring to. So when somebody has, for example, pain in the back of their scalp, you can think of the C2 dermatome as that might correspond to this region. Of course, if you guys recall, that would be your greater occipital nerve contributing up there at that sensory portion. All along the neck, we have C3, C4, C5, and even a little bit of C6. So if somebody's having pain along that posterior aspect of the neck, then you could think, well, maybe there's some type of compression of these nerves, assuming it is a compressed nerve that's causing that pain. A lot of different sources for pain. You can see as well a C5, C6, you might refer to some type of shoulder pain. So here we have a C5, C6. That might be, if you think about when you have to rub your shoulders, you can just kind of feel that pain up there. That might be the sensory of that area. And then as we move down and we get to C7, C8, you can start thinking about the posterior scapular area. So when you put your hand along the back, you palpate above that spine, that would be those dermatomes. Fortunately, the thoracic area, that's pretty much all straightforward. That corresponds very nicely to your thoracic nerves. So as we go from T1 to T12, all that area of the back, that should help you narrow that down. Same thing with the lumbar area. So here we have L1 through L5. As you can see, that's going to contribute to the lower back. As you get down to S, the sacral region, you'll notice that S1 and S2, as we can see here, are corresponding to those posterior thighs. So we mentioned the sciatica before, either occurring at L5 there or S1. That's, the back of the thigh. And then we can see that S3, S4, and S2, these are going to actually refer to the perineal area, right? The perineum. And that refers to the area between the, not S5, let me get rid of that one, the anus and the genitals. So that would be that area. Other useful landmarks, which we don't see on this picture, T4 corresponds to the nipples. So here's T4 on the back. If you were to turn anteriorly, that's about the level of the nipples. So if you have some type of pain, even if it's not the nipples, you can still use it as a reference, as a landmark to whether to go above or below. T7, the xiphoid process, that's that inferior aspect of the sternum. So as you go down to the body of the sternum, you feel that big bump. That's your xiphoid process. That's going to be T7 dermatome. Another big one is the T10 dermatome. Here it is at the umbilicus. So think of your umbilical, your belly button. That's going to be about that area on the anterior aspect of the individual. Do keep in mind there is some bleed over, so these guys do kind of cross. It's not exactly perfectly mapped like this, but with sensory, it's very nicely done. Motor is a different story, but sensory works pretty well. Also remember that we're referring to everything but the face. The face itself is actually supplied by cranial nerves. So we'll have the trigeminal nerve, for example, giving the sensory from the face. And so we'll deal with that in a separate segment. Another thing to keep in mind is the difference between a dermatome and a cutaneous field. So when we're talking about a dermatome, we're talking about the entire surface that's being supplied by that one spinal nerve root. So in this case, it's C6. However, because of things like our brachial plexus, where the nerves will leave, they will come together, they will mix, they will separate again, each dermatome can actually have multiple nerves going to it. So we'll use another thing called the cutaneous field. The cutaneous field is the amount of surface that is supplied by one nerve. So we can see here, this is the cutaneous field of the lateral cutaneous nerve of the forearm, supplying this area out here, but not all the way up to the wrist. And then that lateral aspect of the superficial radial nerve is going to supply that lateral thumb. Excuse me. So you can see, guys, that the C6 dermatome is being supplied by multiple nerves. And that's the idea that we're showing here. So don't worry about memorizing all this. Just remember that this is the dermatome over here. And then over here we have our cutaneous field. And once again, you can see the similarities and the differences. So for example, we can see that T1 on the medial side of the forearm is going to be supplied primarily by that medial anti-brachial cutaneous nerve. And that looks like it's pretty one shot, except for down here where you would also get the palmar branch of the ulnar nerve. So just to show you how these guys are related. Once again, this kind of shows us of the pathway of a dermatome. So here we are at the C6 root. And as you can see, as we start to go out to the trunks and to the divisions and to eventually the cords and the branches, you can see these will start to separate. And so now we have the dermatome of C6 that's supplying that area, but we can see that they've kind of taken different ways to get there. The reason this is important, we'll go into more detail about this with the brachial plexus, is because you can have damage along that brachial plexus. And depending on where that damage is, it can affect one or the other or both of these nerves, right? So for example, if you have a damage or a lesion at the root, both of those nerves would be gone. That whole sensory field, that dermatome would be lost. But let's say that you just have some type of lesion out here. Well, now you're going to lose sensory to this area, but as you can see here, this dermatome would be spared. So it's very useful to understand these pathways as we start talking about where the injury could occur along that brachial plexus. This is showing us the cutaneous nerve. Once again, you can have damage along the different ways, but this is showing you exactly where the superficial radial nerve would be, and this is showing us where the lateral cutaneous nerve of the forearm would be. Our musculocutaneous contribution. We'll talk about that later. Another thing I want to mention is a spinal cord shock injury. So this happens after some type of traumatic damage to the spinal cord. It doesn't have to be a lesion. It can just be maybe some type of compression or some type of accident. The point is, what happens is after some type of injury, I don't know if it's because of a protective mechanism or maybe the inflation chemicals that would involve this, but the spinal cord becomes suppressed. It doesn't respond like it's supposed to. So you can stimulate it, but it doesn't want to work. So there is this kind of transient depression, or maybe in some cases a complete abolition of the reflex activity. So you can do that whole knee-jerk reflex, and your knee doesn't work at all. Or you might get some paralysis to that area. So the thing is, after time with this type of injury, it will typically start to recover. It does take several days often. It might even take weeks or even months. And what will happen is after it starts to recover, that slow transition will actually start to lead to spasticity. So it'll be kind of hyperreactive or overreactive for a little while. So you do the knee-jerk reflex, and then your leg just kicks way higher than what it's supposed to. Give it time. With time, it should resolve on its own typically. So after that spasticity and that hyperreflex activity. Then we also want to know, last but definitely not least, where an injury can occur along the spinal cord. So we're talking here about a complete transection of the spinal cord, not a hemisection, not just some compression, but a complete transection. The idea here is that because the spinal cord is the main communication between your entire body and the brain, anything below that lesion will be affected. It will be pretty much lost. So any type of transection will result in all loss of the sensation and voluntary movement from inferior to that lesion. Notice as we begin, we're going to start with the C1 to C3 cervical nerves. So these are right at the very top. And as you can imagine, these guys here being way close to the brainstem, that's going to pretty much cut function of everything below that aspect of the neck. So this is what we like to think of as quadriplegic, right? They have, or tetraplegic, either way. You've lost both upper limbs and lower limbs. Not only that, but you've also lost the ability to breathe because the phrenic nerve is C3, C4, C5. C3, 4, 5. Keep the diaphragm alive, right? With the biggest contribution coming from C4. But because we've transected above C4, we would have lost that diaphragmatic function. So this would typically be a ventilator required for that respiration. Now let's say we go a little bit lower. So now we're below the C4. We're at C4 to C5. Here, depending on whether it's the transection is at C4 or at C5, you would definitely still have the quadriplegia, but respiration can now occur because you might have contributions from C3 or C4, depending on how that transection would work. You might need some assistance, but for the most part, the big thing here, C3 or C4, C5 injury, as we can see here, is tetraplegia. Respiration is intact, but not the function of the upper or lower limbs. Now, as we move down below, we're in C6, C7, and C8. Here we are at the inferior aspect of the brachial plexus. So remember the brachial plexus is C5, 6, 7, 8, and T1. So we're kind of right in the middle of it, if you would. Because of this, you're going to have a complete loss of lower limb function because the entire lower limbs was everything below that. And you would also have a loss of hand and very amount of upper limb function because you've transected some of those roots or cords or divisions, depending on where it's at, along those parts of the, actually this would be in the spinal cord itself. So all that would be gone. But you would still have a little bit because you would have contributions from above that brachial plexus. C5 and C6, for example. As we move down, T1 to T9, so now we're in the thoracic area here. This is going to result in paraplegia, result in paralysis of both lower limbs. So now you would still have the upper limbs, not still, but now you would have the upper limbs function fully because you're below the brachial plexus, so these guys would work just fine. But now the trunk, the lower limbs, they would be affected. So everything below those areas there, T1 through T9, depending on where you're at. As you start to go down into the lumbar area, T10 to L1, once again, you're below the brachial plexus, but now you're also below the trunk. So your trunk should be just fine. Thigh muscle function should be somewhat okay because you're starting to deal with a little bit of that lumbar plexus, but you're going to lose a lot of those functions that we'll talk about. So you may need some long leg braces in order to compensate for a loss at that level. And last but definitely not least, L2 to L3. Once again, we're in the lumbar plexus in this case. And so any transection here can affect the lower parts of the limbs, right? We're thinking on legs here. Thighs are okay, but now we're in the lower part. So you would have most of the leg function for walking. That'd be okay. But you might need short leg braces for walking. So because you're dealing with the feet and whatnot, the lower parts of the lower limb. So there you have it, guys. Some basic spinal cord injuries. Knowing where those transections occur can help us identify where that lesion might be.